Thank you so much, and thank you for this very interesting session as well, which I think is a good segue into our next one on personalized medicine strategies and applications, so genomics and molecular medicine. So we have some very good speakers here with us. So Dimitar Georgiev from Bulgaria and the host of this, Metspalu from Estonia, Allan Stensballe from Denmark, Bettina Ryll from Sweden, and Vessela Kristensen from Norway. So Dimitar, can I ask you to take the floor, please?
Yes, thank you very much, Bogi. It is my pleasure to be the host of this event and actually also the host of this meeting dedicated to personalized medicine. Personalized medicine made, let's say, a great advance in the last 10 or 15 years, and it started first with oncology. But later on, the personalized medicine or precision medicine onboarded also other diseases and other disciplines. And now we see a full spectrum of personalization also in neurology, psychiatry, rheumatic diseases, and hopefully soon also in endocrinology. Also, rare diseases are now a part of the personalized medicine, and we see a lot of rare diseases which are treated only after a profound genetic testing. So now the first question which I should ask to you, Bogi, is you are a futurist. How do you see the future of personalized medicine in the next 5 or 10 years?
Yeah, so I think there are many ways to look at this, and it's both how we want to approach technology, but it's also where we are in it. I do think that what we heard in the end of the last session on that it's not as simple as we thought 10, 15, 20 years ago with direct linkage on simple things. But we are reaching a point where most societies and research entities and also companies are realizing that if we really want to work with personalized health, personalized medicine, more precision in it, it needs to go much more cross-border. We need to connect much bigger data sets in different ways. And we also have a conflict between the huge appetite for making huge data repositories with anonymized data, while we know that for the clinical need, there is also an importance of having linkage data where we can use the person's own data and having that connected in a more complex way. So we know what we compare. While I think technology is there for much more than we do, our biggest bottleneck right now is to develop a new way of thinking. How do we work with health, and probably move our focus from protecting data to protecting individuals when we use the data, because that is what this is about. So we need to get the discussion back onto what medicine always has been about, helping the individual. And having that in mind, and also having in mind that the technology is getting to a cost level where we actually can expand in much more than just the richest countries. So the volume will help us a lot. So I'm quite positive on what is possible, but I'm quite cautious if we can get the mindset and the political frames in place that are necessary to enable this promises on it. So I do think that we will get some rapid expansions of, for instance, pharmacogenomics in middle income countries around the world, because it's something that is doable and the technology is there. While I go on two directions with either the person's health goes in pockets and it will only stay pockets, or we get an alignment on how we work together and then it becomes global in it. But it's not about the technology, it's about if we can align on how we want to work with it.
Thank you. This was very interesting and also impressive because we know that you have a very profound knowledge in personalized medicine and your forecasts are usually correct. So, Allan Stensballe, you are the next for the question. How do you see the future of personalized medicine in terms of genomics data and application of the genomics data in personalized medicine? Now we have a relatively strict approach to use companion diagnostics as the first step. Do you think there will be other options for this?
Yes, so from my side, I'm actually not working from the genetic background, but actually the proteomic background. And in Denmark and many other research areas, we try to optimize more or less the use of proteins as rather than genes, also to look for disease outcomes that could be personalized. And right now, the forefront of my technology platform, which is protein mass spectrometry, there we can definitely now look for phenotypes that were previously only associated to genetics, but now we can actually see everything also, starting to see these markers here on the proteome side.
But do you think that proteomics will be able to replace genetic companion diagnostics soon or late, or in a way be competitive at least?
It would definitely be competitive. So as genomics had a revolution 10, 15 years ago, the same revolution is ongoing at the moment. So right now the recent advances in first of all hardware, but also informatics have improved the ability to more or less make companion diagnostics relevant from more or less linking expressed gene products to disease traits to treatment outcomes. So definitely it's not going to replace genetic analysis, but it's definitely in a clinic going to be highly relevant for addressing treatment outcomes and diagnostics.
Could you please disclose which disciplines will be benefiting most from proteomic analysis? Would it be oncology or also other diseases?
Right now, oncology is by far the most utilized medical specialty that uses proteomics. It's both as a biomarker panel, autoantigens, but I see in my research network, but also at the Danish hospitals, a growing interest in utilizing proteomics in what do you call in autoimmune diseases and inflammatory diseases.
Thank you very much. I have seen from the organizers that the gender balance of this meeting is totally disrupted. The female speakers are not attending because Bettina is supporting Ukraine in a way, and Professor Kristensen is not able to attend. So the next one is Andres, and Professor Andres has slides. Professor Andres, would you be so kind to start with your slides, please? Yes.
Okay. Now I have to. All right. So first of all, thank you very much for inviting me. And so because we don't have too much time, I just go ahead. And you know, my approach is that what I'm really thinking, how I think on my vision is that we should really put more attention to prevention. And you know, treatment is going on when you have a patient, but now, like Bogi was saying, you know, we have to change the kind of a mindset. We have to change the concept that now, if I are going to talk to doctors, that okay, we have seen a healthy person, but disease risk is high, So doctors are telling me, look, we have enough patients to treat. Now you are bringing in some kind of a healthy ones. But you know, so I have this one slide kind of vision what we have been doing in Estonia and advancing. We charted 20% of population and they are running this pollution risk score. And basically we got 50 euros per individual from government, which allows us to recruit a person, get blood, get DNA, to genotype it with high density SNP array, put everything into database after QC and run a pollution risk score. But you have to have information from GWAS studies before you can do it. Now you can do it for 100 diseases. So, and at the end of the day, you just can take 1% of very high risk people who have this high genetic risk for disease. And this is basically the high risk is high from day one. Now you're getting older, you have lifestyle things, you have environmental addition, and of course, finally, you get also proteomics, metabolomics, and everything. But this is already changed when you're already getting closer to disease. Your blood pressure is normal when you are, 25, but your genetic risk for MI is already high. So you can do something. And this is a full concept. So basically, in order to manage healthcare preventively, we have to genotype the population, basically. 50 euros per piece, per individual, and you can do it. If you have 1 million people, it's 50 million. If you have 10 million, it's 500 million. We are building now in Tallinn a new hospital for 500 million euros. It's just one hospital is enough just to genotype the population of 10 million people. Okay, so I just give you, now I know how can I move. I can't, okay, here. Okay, so now the question is, Europe is like one, and so how different or similar we are in Europe. So basically, this is a zoomed in map of principal component analysis that you see. Finns are a little bit, far north, but the rest is more or less in one side. If you put the Chinese here or African people here, Europe is still one spot. So we are very similar in Europe. Of course, now Europe is more complex because we have lots of minorities from different countries, but let's say the old Europe is pretty homogeneous, and we can use the sequence data from across Europe. There is a 1 million genome project, which I would like to stress that this is very important thing, and Bulgaria is part of it. So you would like to sequence 500,000 people, and this is a database which captures maximum genetic variation, and you can use this to impute your race, which are running in local place. So it's a now. And I just give you quickly 2 examples where we use genetics or genomics to start with. Take FH, and we just only took 3 genes and took loss of function variants from this sequence data and invited these people from biobank to cardiology hospital. And of course, the problem is that, lots of people have a very high genetic risk, but still LDL, cholesterol is pretty normal or close to normal. But what happened? He invited these high-risk people, and most of them had absolutely no diagnosis. And some of them had diagnosed like hypercholesterolemia, which basically, and only 3 had FH diagnosed. And after visiting the hospital, most of them got the FH diagnosed and treatment. So this is a disease which is under-recognized. So basically, lots of these patients are seeing the physician the first time in emergency room in hospital, and quite a few are not coming out of it. So this is a simple thing. You have to have a DNA first, and you know nothing, but just you have people who have very high risk. And I don't know any other method which can predict and find up high-risk patients with such efficiency. So of course they got treated afterwards, and they had no treatment before. You definitely save life here. Now let's take the breast cancer as an example. Of course we know the familiar worms, but this is like 10% of the old cases. Most of them are new. And so if you just put I go here. So if we just took our breast cancer patients from the biobank, so and this is population average. We all know that about 5, 6, 7% of women are getting ovarian or breast cancer before they get 70 years old. But some of them are getting, this is much higher, and some are much younger. So they don't get, so people are different on this. And if you just take a top 5%, you see, this is a population average, but top 5% is here. And what it tells that and in population, 70 years is here, but high risk people, this is here. So that means it's 50, it's you get breast cancer around 50 years old. So it's almost 20 years earlier. But now the breast cancer screening starts at 50. You have to be a woman and 50 years old in order to get invitation to go to mammography. So for lots of these women, it's already too late. They are already gone. So this again shows that you have a genetic risk, which really tells you that you have to focus on certain subgroups. You have to stratify your all women, and you see you can be more effective if you just address your limited funding for prevention just for a certain high-risk group, and you get it much better results. So, and what on top of it, of course, we can take these 100 diseases. Every disease has something like 1% very high risk, and in most cases, you can do something. Even in Parkinson, you can do something because it's a lifestyle thing, but at least the pharma companies can see you can predict it probably many years before. And the same thing is for many other diseases. If you know that this risk is coming, you can do something. But now we are just driving, closed eyes into the curve, and we just go straight into the valley. So, and other thing, it's not only genomics, it's also decision support systems. It's a computer, AI, and all systems. They should really help primary care provider, because prevention happens on primary care level. So, but these doctors are really overwhelmed. So they need help. And, they are based on genetic data. This can be calculated what the risk is. You get your 2,000 people in your list. You get, okay, this person has very high risk of something. I invite and tell, look, this is something you have to take. You take a bill, or you have to change the lifestyle. And, this is a way to manage. But genetic data are cheap to generate, and now we can use it already today. I agree. Proteomics is closer to this. It's in a way, as predictive value is higher, but it's much closer to the disease. And probably to avoid disease, it's sometimes it's already too late. So it comes like this. You have a if it's already raining outside, you don't have to be a rocket scientist to predict, okay, it's going to rain, but just to predict rain 10 years before, this needs, some knowledge. So this is my conclusion that, basically the biobank concept is good, but it's now we have to move on to the population level. Biobanks were just a sandbox, little, proof of concept thing, but now we have to acquire most of the population into the databases. Everybody has to be genotyped, and I know not all are ready to be genotyped. Not all wanted to take a vaccine, and they are ready to die, but they don't take a vaccine. Of course, but if we, as a society, we have to match the majority. And in our country, 75% of people are supporting what we are doing in Estonian Biobank. And so basically, people are very much interested. 5,000 people received feedback from Biobank, and not data from Biobank, but of course, people who really deliver the information were physicians. And basically, people were very happy. More than 95%, people were happy. Even 6 months later, they said, look, this was very right decision to what I did. So nobody's really, very few are kind of tense and worried and so on. But vast majority are really happy. So this is my message. We have to go on population level to centralized system to genotype, so that government will provide the data and money for the genotyping, and then you just apply the software for polygenic risk scores, how it goes, because the information is coming every week when Nature is published. You get the new SNPs, new whatever, but your tools are improving. But finally, the genetic data is staying. And of course, you can use the same data also for research if you have a legal and ethical landscape properly designed. And so it benefits lots of things. And if you're doing this large-scale thing, actually the system is teaching yourself and itself, because you see a variant, you see how the treatment was, effective, or which was not effective. You can take it into account. It takes a circle, and you just improve your thing. So I'm not talking about pharmacogenomics. We have the same data on pharmacogenomics and several other diseases. So it's very promising, and it's not expensive now to genotype the full population. And for Bulgarians, I tell you, go and look. 1 Million Genome Project is 12 work groups are preparing all different aspects, starting from governance and healthy, ending up with Genome of Europe or COVID as infection disease. So this is very good. You are part of it. There are a few countries from Europe which are still not, but are just observers or joining, in process of joining. So this is my message. So we have to think differently and do more prevention. Treatment is also necessary, everything, but more prevention. This is what we are lacking now. Thank you.
Thank you very much. This was really very interesting presentation, and I have noticed one question about the decision support tools, which I will put later on. But now I'm happy to say that the gender balance in our session has changed a little bit. Dr. Bettina Ryll is here, and she will speak about patient centricity. Dr. Ryll, welcome. Thank you for joining us, and thank you also for your continuous support for Ukraine. I have heard from my colleagues that you are supporting us. We do as well in the turbulent times today. So, Dr. Ryll, the floor is yours. Please go ahead.
Thank you so much for that kind introduction, and it's a great pleasure to be here, and actually nice for a moment to talk about something that, like I say, maybe until two weeks ago I would have said was the topic that I'm thinking a lot about most. And then, of course, I think we have all been overrun, or at least the Western parts, and this is what we have all been busy with. I, however, fully agree with my colleague from the Cancer Mission Board. It's always good to see, Anders, that prevention is something that we have to think about differently, and especially in terms of personalized medicine. And if we just try to lift our gaze a little bit from the horror that is going on right now in Ukraine, and just take a little step back and think about what we're going to find in a year, or in 2 years, or 5 or 10 years from now, and what our societies will then look like, and what we will have to deal with. I think that's a very important thing, however hard it is to do now, because this is what we have to start and prepare today, that in 10 years we're in a different place. In a peaceful place, but then also in a place that with healthcare systems that benefit everyone, and to equal parts, and that are sustainable despite all of it. So if you now think about personalization in medicine, and why that is such an attractive and important concept for patients, then it would be that I'm a trained physician. What we are taught in medicine and how we usually think about patients is we think about patients in groups. So we pretend that we have homogeneous groups of people and think of them as one entity. And that never struck me as anything odd as a patient, as a student, because when patients came to us, of course, you try to group them in order to inform your decision. However, what struck me when my husband then was diagnosed with stage 4 melanoma, all of a sudden you on the other side of the table, you realize that the perspective very much changes, because you start worrying much more about how do I fit into that group. And all these percentages, however p-value there might be, all of a sudden are not so certain anymore. Because, I mean, I am now in melanoma. At the time, you know, if you have something like a survival of 50%, that's the flip of a coin, whether you're going to live or die. And that, of course, is not acceptable at all. And that was a little bit the entry point for our perspective, how to go into a personalized medicine and how to get better at optimizing outcomes for ourselves from a personal perspective. If you then move up and go to the systems perspective, it also makes sense to think about personalization from a systems perspective, because what we're doing now is a one-size-fits-all. Anyone who has ever bought a one-size-fits-all t-shirt knows that's a terrible idea. So for healthcare, that's even worse. If we do this in healthcare, some people will get more care than they need and should be getting, and we should not forget that also care comes with a burden to the person who are subjected to it. and some don't receive enough. So by optimizing on the single person, we optimize outcomes while keeping within resources. So under that perspective, that makes total sense. And of course, the situation right now has changed geopolitically, but for example, China and also Russia take that approach very deliberately to using personalization in order to optimize resources. And then, of course, and that is something that the Cancer Mission Board has been discussing for a long time, if we think about cancer and then cross with personalization, we have to think across the entire spectrum. We all have our favorite topics. I'm sure you have now picked up what my colleague's Andres topic is. But if we really want to get rid of cancer, we have to be effective from the beginning to the end. That means we have to prevent as much as we can. None of us wants cancer. It's not that, you know, we tick a box. So the best is the cancer. The best cancer is the one you don't get. But some will get cancer, whatever we do. And we should not forget that prevention has a long timeline, 10 years, 20 years, 30 years, 40 years. So we have to deal with a backlog. So what if we cannot prevent it because the event might have been in the past, or humans are humans and they will still get a tan because they think it's beautiful. I mean, education, just a little sideline. If you want to see how effective education is, then go for sun-tanned oncologists. Then you will see, you know, what I believe how effective education alone is. So you want to pick up where it goes wrong. So early detection is critical. And there, of course, Anders has a very valid point. The better we get there in combination with personalization, the better our outcomes. Then comes the treatment path, and we have to allow people to get back to a normal life. No one wants to be a patient forever. And with the number of cancer we're having in our societies, that become more and more important. So I think it is this kind of cross of thinking holistically, prevention, early detection, treatment, and then going back to normal, though no one will ever be going back to total normal, and cross that with personalization to optimize outcomes. And in the last, I have a timer on because I was, I'm aware that I'm not supposed to be over time. An interesting piece in there that I've been working on recently is how we get this done. Because we can talk, and personalization is very attractive because it makes so much sense, and the right drug to the right patient at the right time sounds really catchy. But the trick is in how do we get this done? Because at the moment, our entire system is optimized for what I call groupthink. We think of patients in group, we approve drugs for groups, we do HTA on groups, we use drugs in groups. Our systems are processing patients in groups, they're scheduled in groups. If we want to personalize, we have to change that. And that's a system shift that is deeper than, the right drug to the right patient at the right time might actually show. To give you a very simple example, at ASCO 2018, in the plenary session, Bash et al. Presented results that by using a simple digital tool asking cancer patients with advanced cancer to report their quality of life on the EQ5D, which has 5 items, which is super basic, and usually we don't like it, therefore. It has been, and then once a patient showed a deterioration of quality of life, calling these people in and starting the follow-up at that point. They were able to prolongate the overall survival just by that, without any new drugs, any other thing than just bringing forward an intervention that otherwise would have been scheduled at a fixed interval. If you're interested in the process, I can recommend a book. It's called Solving the Efficiency Paradox. And it is thinking about flow efficiency versus resource efficiency. And this should have been, you would think it's a no-brainer to implement it at scale. But because it effectively means that we have to change the processes, how patients move through the system, it hasn't happened. So it is easy to talk about it. It's a very attractive concept, but we shouldn't fool ourselves that the implications, how we organize, how we work, are deep. And that we really, if we're serious about it, we really have to think holistically across these different levels, the entire spectrum of care, personalization within it, and then think about what it means also organizationally, structurally, how we organize our workforces, how we train our workforces. And that if we really want this to move, we really have to start working together in a way and using and finding mechanisms to do so effectively. So that might have not been what you would expect from a typical, a patient perspective, because often when I go to places, everyone expects me to just be fantastically grateful for everything that's happening. I think we're in for a phenomenal challenge. But I do believe, whenever have we seen the urgency of what we're doing, or how much it matters, how successful we are in what we're doing. So I believe if the time to change something, if there was a better time, I don't know when it would have been. So I think now is the time to move and do something about it. So thanks for inviting me. Thanks for being here. It's always good to see colleagues. It's always good to see how things are moving from the last discussions we've had. And back to you. Thank you.
Thank you. Actually, this is what I exactly have expected from this presentation, honestly.
Good.
Now I know better what means to have skin in the game, because you are the emanation of skin in the game from patient perspective. Thank you very much. I am really touched by your presentation. And I have a specific question for you, which comes from the audience, but it fits. But this will be next. So now I would like to ask Anders and Allan about the decision support tools. Anders, could you explain please more about the decision support tools, how they work, and what is in these decision support tools? And then the question for Allan would be how proteomics would fit into the decision support tools. And then to Bettina, how patients see the decision support tools. So Anders, please, the floor is yours. You are first.
Thank you. So we almost for every case we have to develop a specific support tool. Let's say in pharmacogenomics, the support tool works like we just feed in the genotypes, and we have information which is coming from CPIC and known information how which variants are important or which are how metabolizing which variants are metabolizing drugs faster, slower, and so on. So all pre-existing information is in, and then you just feed in the genotypes, and you just get a printout. Okay, this drug is no good. It's just like a traffic light thing. It's red, and it comes out that there is something which is adverse reaction for this drug, and the system is not recommended yet in our case a new drug, but actually tells that look, you have to change the drug. And there are other variant which is a kind of yellow, tells look, you have to look into those. It's just too much or too little. And then it's when it screens, then go ahead like this. Because in our case, we have all prescription digital. So we get also information what people are getting. And we have more than 200,000 people in the biobank and digital prescription data. So we see what people are taking and how they are behaving and who ends up in the hospital and so on. So we have lots of information to build it. For other diseases, like let's say cardiovascular disease, we have a system which really takes it into account also like BMI and a few other things, and age, of course. And you can actually calculate the risk, and you show it for some people. So look, if you just keep your body mass like it is now, in 20 years from now, your risk is like this. But if you reduce this, your risk also gets lower. Or if you just don't keep, your diet, body BMI gets higher, and your risk will increase. And this is something which really people like, because they see, okay, I can do something myself. And even the GPs are really telling that, look, people are really, you just can use this tool and show that people, they have something what they can do, not only taking a pill or something, but this is something which really is kind of, for many, this is convincing argument to follow the lifestyle change, which is very difficult to keep. We all promise lots of things, but if you just have a doctor's thing and you are following it up every, few times per year, then it's helpful. So this is something we have to, the thing is now that there are too much data. So what we are using now is mostly genetic data, but there are tons of data, but to incorporate all the data is so far difficult. There are quite a few projects going on how to increase input, but I'm not sure whether this all improves the outcome. More data also generates more noise. And so I have to make sure that, there is one thing we have to make sure that perfect is not the enemy of the good. And we have to make it quite a robust thing that everybody can use it and understand it. If it gets too complicated, You know, I had a VCR machine at my home, and I couldn't really program it. My you know, son, who was in elementary school, did it in a few minutes. So it's we have to take into account that if things are getting too complicated, and then they are not really not going to be used widely. But what we need it used widely, and system must be robust, but must have a scientific base. So that is most important thing, is to have a kind of a group of people or system, how it works, that you can incorporate all the new knowledge into your algorithm, that you know that you are on the top of the evidence all the time, and using the new evidence.
Thank you. So what I understood is that you suggest to have decision support tools both for patients and for physicians, which are separated. Is that correct?
No. It's just one tool. Patients don't, in my vision, patients don't, you know, you can, of course, have these things in your phone or something, because there are lots of this type of commercial stuff. But what I'm talking is primary care level or physician level. It's for tool for physicians, that they can know what they should know, what to talk to people, what to tell. Because now, what our feedback from the primary care level is that we trained 80 doctors, which is 10% of our GPs. We trained them, and their feedback is that they really like the tool, because this is something hard evidence. They can tell, look, this is your problem. But because people are coming all of sort of complaints, but if you see that there is a fundamental genetic issue, then you know where to focus.
I see, because Professor Lauschke in the previous talk spoke about patient centricity, and that the patients are taking the wheel in their hands, doing pharmacogenetic testing.
I see it also happens, because I think that it has to happen, like at least once you have to be at doctor's office, and doctor can tell you, then you can follow, you know, your phone, and you do things. But I also see that it's like a democratization of the healthcare. Everybody's doing their own healthcare. But you know, I have little doubts, because not all people are equal, and some can handle this thing quite okay, and some cannot. And so I have to make sure that these who cannot are not making wrong decisions for themselves.
Exactly. Professor Stensballe, what do you think about decision support tools in proteomics? Allan? Oh, he's probably not online anymore. Bogi, what do you think about decision support tools?
Yeah, no, I think decision support tools are a necessity that we need to work with. And here, I mean, this is one of the places, and thank you for all the inputs that we have had. I mean, which really also speaks to what I started with. What is it we need to change as a mindset, and coming into what Bettina also was mentioning on how do we do this holistic also requires on how do we think the value of the health intervention that we do, because it needs to go from the treatment in a year or a couple of years to the lifespan in it, and how do we then begin to think about health span in this way, and here we would need to work with a much broader picture. So if we don't get decision support in several ways on it, it's probably not realizable. And the decision support that is apparent to us right now is more on the technical medicine level, which I think we should work with. But I do think that if we come back to some of Bettina's comments as well on being more advanced on personalization, which also needs to get us to the humanization of health. So how do we begin to leave the patient thinking to a person thinking, and integrate people and get them included as much as possible? Because I think the thing that we are losing out on a lot is the potential of secondary prevention. So how do you optimize everything around the treatment in it in order to get the outcomes better? And that actually requires a totally new way of thinking health economics, where we see health as an investment into the population. So 150 years ago, we invested in machinery and we got the industrialization. Now it's a knowledge society. We have to invest in people. That's what is going to give us prosperity and growth forward. And the decision support we can do now, we need to do it, but that's only the beginning on how we have to expand that going forward. And I think just a last comment on it, I think the discussion with in concern of genomics and proteomics. So proteomics and the new biology, different omics levels, several of those are more instant. Yes, they are closer to disease, but they are bedsides which we can activate right now, while the genomics is also very much on the preventive side, and we will get more of the omics in on that side going forward. So I also think it's important to get that in when we want to work with the decision. But decision support, yes, we need to really work on that.
Andres.
I just short comment. Now that genomics is very useful for risk prediction, but we have to keep in mind that data are coming in more and more, and from hospital data also, we can do the disease progression, which is even more important, because risk can develop in different ways, but disease progression is also pretty much genetically analyzable, and it involves more proteomics information. So, and also the treatment outcome. So how to treat? In some countries, ovarian cancer is treated 150 ways, but because people are different. But you have to use also the same tools. I mean, the same information together with other omics data in later how disease is progresses. But at the beginning, it's just inborn risks that it comes with you, but you're getting from your parents. So I agree completely. Decision support is important, but we are only on the square number 1 now, and we have to move.
Good, and now I'm extremely honored to have our fourth speaker, Professor Kristensen. So once again, the gender balance is completely okay. Now we have excellent gender balance. Professor Kristensen, you came a bit late. There was a very nice contribution from the panelists regarding the role and place of genomics, but also proteomics in personalized medicine. What's your view about genomics and also about proteomics in personalized medicine?
Well, I'm a molecular biologist, and I don't see proteomics as a distinct part of omics altogether. My view also as a molecular biologist is that these signatures created by I'm sorry, I'm a little bit distracted because I just arrived for another conference that I need to attend. Clearly we have had in the clinics, in pathology, a number of markers, clinical markers, that have been widely used for breast cancer. I work with breast cancer, so that's what I know. So there are a few things that we know about breast cancer that are certain. For instance, that they are either the cancer cells expressing the estrogen receptor on their surface or not. This is very important for guiding the treatment, or other factors like that. So I see the omics as something growing out of these few things that we've known from the 60s and expanding the number of features to a whole genome, which of course at the end is not going to be necessary. But on the other hand, being able to do these analyses whole genome allows us to identify the parameters or other features that we could use in our prognostic and predictive models. So I certainly think that the role is there. And I certainly think that the complexity of the problem, to what also Anders alluded, the fact that we doing things whole genome have a type 1 error, which is so that we can never have a certain response. The number of patients we test is always fewer than the number of features we study. So far this has created this gap, which has allowed maybe even to skepsis and in this uncertainty to grow. But I think that there are more markers than the ones that we now currently use in the pathology, and we are actively discovering them. And I'm sure that with time, for instance, breast cancer specifically is a very good example of subclassification of cancer, which also indicates new treatments. And the proportion of patients who do not at this time get good treatment options is getting smaller and smaller.
Well, thank you. That was really very interesting and opened the door for a complicated and also interesting question from the audience. And the question is, I will now read it. How the new precise early diagnostic toward the treatment methods could be accelerated, ensuring affordability to them, avoiding inequities in the healthcare ecosystem from your perspective as researchers and also people in the practice. And I think Bettina is the first one to answer this question with her engagement for patient centricity. Bettina, please.
Well, all these questions always have so many different levels, and then it's a bit hard to be short about it. So I think that the first thing, patient centricity, it's a good PR gag, because I mean it's a bit like, you know, everyone cares about children. You can't say no to not caring about patients. So I think it is often used for PR purposes, and that's of course something I'm not particularly interested in. There's also this kind of tendency to involve patients all over the place and sprinkle the patient voice over whatever we do. And that is what I call surface decoration, because it never really touches the core of the issue. And that, I think, is something that we all have to to separate intellectually, because if you really think, especially about personalization, how we're going to get it into our systems, what we're having at the moment is a chain of different things that have to happen in order to personalize. Usually on the basic scheme, it is a diagnostic, usually followed up with a decision support, as we have already heard. Then there will be a treatment choice, and then a result happens. So that happens to the patient. But someone also has to pay it or has it. So the system on the other side has to kind of be able to react to it. And we have already heard that health technology assessment at the moment can't deal with these chains. We know that. They take one item at a time. They are unable to deal with this complexity right now. And then, of course, HDAs don't exist in an open frame, but they are under political, they have a political mandate. And if you think about all of these stakeholders, the only one who binds them together is actually the patient, who is supposed to benefit from these interventions, but who's also paying into the insurance. It's a voter, it's a citizen of a country. And the only person who unifies all kind of that, on which one can focus or through which it has to be channeled, is the patient. So all this kind of the patient at the heart of everything apart, it is the only factor in this chain that kind of unites it. And that is something everyone then kind of has to agree on, because the politician listens to voters. Health insurances, depending on the country, more or less, listen to those who pay in. And so, you know, I think it is kind of the key factor we have to get right intellectually to align our systems to make it to work on a very practical level, independent of it being, of course, and of course I have to say that as a patient advocate, the right thing. Our societies are changing. Our societies are moving to expecting a higher level of individualization. They're expecting a higher level of involvement, of being asked, of tailored services. I mean, you can today tailor nearly anything, but not your healthcare, and we expect our societies to accept that. I think that's a political mistake. That is something that will not work. What we have already seen, when healthcare systems try to standardize and restrict too much, the only thing that is happening is that alternatives pop up. And what that then does is it drives inequality and makes worse what we try to prevent from the onset. So if we are not careful, too much not listening to what patients, and some call them consumers, want, will drive an alternative system, driving inequity. And that's dangerous for our societies. So I think from that perspective, it is a concept that's helpful, and it's really not helping to have this kind of, you know, PR good meaning sprinkle on top of it, because I think it creates an, you know, reaction from people going, oh, that's just PR, that's just superficial talk, that's never really touching the problem. And I think it's really time that one takes the fluff up and really thinks conceptually about it. And that's my interest in the topic, because I don't know who else would be able to drive it. If you think about any stakeholder in the system, anyone has a vested interest that blocks the others. The only one everyone kind of can agree on, more or less, is the patient, who themselves doesn't have that much active power driving in there. So I think that's the value in the concept.
No, but what is actually, according to you, a real patient centricity? what would be the real, because I completely agree with you that patient centricity put on the top of advertising is a gag. But what is the real patient centricity? How do you imagine a real patient centricity in our world?
Well, I don't have the answers to all the problems on this planet, of course. So the way we deal with it is doing right by the person concerned. So what you would like to see in terms of healthcare and what would be right for you is very likely to be different from what I would like to have in terms of healthcare. So one thing for me, the priority, and this is also how we think about the patients in our network and how we try to take care of them, is to do right by the person. And that's, for example, that healthcare is close to the person, that it is in the right language, that it is culturally appropriate, that it doesn't rip a patient out from there and then all of a sudden, in addition to a disease, you have to deal with, I don't know, complexity, different country, different language. So I think that would be the human concept in there, to do right by the person in front of you. Then comes a level, and Anders already mentioned that I think information and what is right for you is sometimes very hard to judge. So I think that we need something like standards that everyone should be getting. One of the reasons why I got into advocacy was that I found it so unbelievable that just because I happen to be a physician by training and have a PhD in molecular biology, I could do things for my husband that other people couldn't do. And I could have studied something else. I could have become a mechanical engineer or an IT person, or, and there's so much chance and coincidence in there that didn't feel right. So I think there has to be something of that even if you don't know what you should be getting, there's a safe way to ensure that you're getting what you should be getting. And that's the problem with this direct to consumer at times, that are not only not giving you what you don't need, but are very much interested in just getting your money. Well, that's something they want, but that's a different issue. So I think there is this level of providing best care, even if the person doesn't know how to ask for it or demand on it, that I put on top of it. And then, of course, you have another outside, it has to be sustainable, and someone very much said so that it's not just about the health we provide today, it's also the health we provide for future generations. And that then, of course, links, for example, with prevention and that. So I think it's just like, it's a complex, it sounds so nice. I don't want the fluff, but if you really drill down, it's a multi-layered concept, a bit like an onion. But at the heart of it, I think it's a human attitude to in the end, suffering. It's a single person affected, and it is how we provide the best around this single person. That for me is patient centricity.
Good. This was a very complicated answer, actually. If I have to put it in one sentence, I will not be able to do this, but still.
Ask me next year. Maybe I have to think a bit more about it, then maybe in a year I have a synthesis, but I'm not there yet.
Good. Bogi, do you think that new diagnostic treatments are creating inequality?
Yes.
So this is actually the sentence of the questions. Are new precise diagnostic tools and new therapies generating inequality?
Yes, I think it does. I agree with Bettina on that. There is a huge bias in the capacity we have for asking in where we end up. So that is the one thing inside the frame where we are, where we can say it's more or less equal in that society. But I think so. I think we need to think personalized health as the person, the community, and the society. And how do we get that to work together? Because it can't only, you have to help on these three levels in order to be able to. Our concern on the inequality, Dimitar, is of course also not just inside the country, but also more on a regional, so European and a global level. Because what we discuss today is only accessible for 10% of the world. And that is the other picture on it. So when and Dimitar, on if we really want to get this technological advances where we get the volume into it, which actually can help more people, we need to get beyond that. It's only the richest 10% that we work with. So that is the big scale inequality in it. So how can we ask both funders, companies, and health providers to focus on, and it's probably equality is not the right term here. It's probably equity. How do we get the focus on the equity so we can work further on this? And I agree on that one. Yes.
But could equity be enemy of quality?
On short term, yes. On long term, no. So that's the balance we need to strike.
Excellent answer. Thank you very much. I think that we have some minutes left to finalize this very interesting, inspiring, and also touching session. And Allan, are you there?
Yes, I'm here.
So what do you think? Could proteomics create inequality or not? Because there were a lot of discussions how modern treatments and modern diagnostic tools could create inequality. What's your perspective?
At the moment, I think also listening to Bogi's last discussion here, at the moment it's I think really expensive. 14 days ago, actually last week, I was in South Africa, being one of the best educated places in Africa, and still the level of technology compared to Western Europe and also to Denmark, where I'm sitting at the moment, is big, really big. But I think that with looking just a few years ahead, I think the cost per analysis is dropping so fast that it's going to be very reasonable. And also some of the technology we're using there, the clinical, like sample preparation, and also what we can do in off-site big laboratory infrastructures, that could actually be done locally, and then we can handle all the advanced analysis off-site, so in centralized key laboratories. So it's actually feasible to actually do at very advanced work in, for example, in Denmark and other European countries, and then level out. But it's going to be, some of the equipment is still awfully expensive and very difficult to implement in less fortunate countries.
Well, but we were there also in genomics,
Yeah.
For example, a decade ago.
Yeah.
How many years do we need to have equity and quality in proteomics? Just a fair estimate.
Yeah, so if we do it as, for example, in Denmark, we have to a certain degree national laboratories, but also regional laboratories that can support more or less the advanced work, and you could do the same in other countries where they don't, where each hospitals, regional educational facilities cannot more or less pay the cost for advanced equipment. But right now we can do a lot of the very manual work off-site, and then we can do the advanced analysis very simply, very robust, centralized. So that would definitely speed up things quite a lot. So I think 3-5 years, then we are actually quite far. So because just the equipment we have in our laboratory, there we could have samples prepared for very advanced analysis in a simple office, in a simple laboratory setting, and then we do all the advanced analysis in a dedicated laboratory setting. It would only cost hundreds of dollars to actually equip researchers for the sample preparation as it is now.
Thank you. Now we are 2022. In 2027, we will invite you to deliver a lecture about the role of proteomics in personalized medicine. And I hope at that time we will have forgotten COVID and the war in Ukraine. Anders, what do you think about equity in personalized medicine?
Equity? What do you mean?
Equality, how access, and is actually new diagnostics making hurdles to patients to get modern treatment?
So of course, say, you know, it's its quality is improving because you have using more data, and this is scientifically justified data. It's, you know, how the medicine is in many sense still art, because you just you have to take into account the variation which have between people, but now you have some tools to assess this variation. So it's getting a little bit less art and more scientifically justified. So it's improving, and the fear that the cost is increasing. So if treatment or prevention is high, then try to be sick, you know. So it's more expensive, and so if we can avoid disease and prolong the disease-free years for people, it's all beneficial for the society.
Thank you. Vessela, I have a relatively provocative question for you. The topic of this meeting is bridging the gaps between Bulgaria and the Nordics. Do you think that early molecular diagnostics could shorten the gap between Bulgaria and the Nordics? You know the situation in Bulgaria, I think, and you know very well the situation in the Nordics. Do you think that this is, in a way, something which can bridge this gap and this big difference?
Yes, absolutely. I think that awareness of the disease altogether and acceptance of the disease and information in terms of, for instance, the disease I work with, breast cancer, has very good prognosis for a very large percent of the population, is very important. And I think that this is not only a scientific, but a societal question, that first of all, people accept genetic testing, accept to kind of live and work with their risk. This is actually not very different in Norway, where I live, than Bulgaria, where I come from. There is some, I feel, like a neoconservatism in society, that sort of learning about your genes must be somehow dangerous, and you should maybe not do that. So I think, like, we as geneticists need to contribute to make it sound as it exactly what it is. It gives you a little better control over your own health situation, and you're also counseled, you're getting help. So this is very important that we both in Norway and in Bulgaria work on. But early detection and early screening, I don't know what's the state of the screening program in Bulgaria, but clearly actually using polygenic risk scores and genetic burden estimates to select women who may even be offered the mammography screening earlier is essential in both countries.
So,
and also,
yes, go ahead. Sorry to interrupt you, please.
No, I just wanted, because while you all were speaking, I was so very much preparing to say my saying about the inequality. So I just wanted to say a word about that too. So of course, if you say that you're against inequality, it's like you're against kittens. You know, I mean, it's not, you cannot be against inequality. But it is of course important to know that personalized therapy is very expensive, and for at least, let's say, again, breast cancer, where I know 75% of the women get very good outcome with very conventional treatment. So it depends on how you measure things. So even in a country which is as egalitarian as Norway, you have inequalities, right? Because those who are treated by conventional treatment are going to be treated much cheaper than those who will have the experimental treatments. And we have in our own clinical protocols, we know that the screenings that we can provide are very, very expensive. And if you see how many women just get enrolled into appropriate treatment based on the screening is still economically not feasible. So I think that these inequalities will exist even in the most how should I say, monomorphic, or the most same, if you only compare Norway with Norway, not even Europe with Africa or Bulgaria and Norway. But I think in a way, this is also a good thing, because if we have a good offer for 75% of the patients, and we only have to focus on the 25% and we spend the money on them, then it is kind of a social contract that among all breast cancers patients or organizations, that we should now focus on those who cannot get help. And here again, I think that the normal genetic variation can help. I'm sorry that I deviated from your first question, because I know that Anders had wanted to say something to the polygenic risk scores.
No.
No.
I wanted to say about education, like you already pointed.
Thank
Yeah,
you.
we have to, if I made a short comment,
You
have
may,
to
of
educate
course.
also people. And it's education is important, and the best way to educate people in genomics is just to get them involved. So get this blood sample and tell, look, we are going to run it, and we just make you a genetic map of your genome. And this involves people already. They are interested. What comes out of it? What about me? And they read the information. And so this is at least in Estonia, all this biobank thing is the largest educational effort ever, for the population. Otherwise, we don't get 75%. So basically, I tell education is the key, and we have to explain the technology, what is behind it, because otherwise, if people don't understand it, they don't like it. And that's why we failed in vaccinations, because people are thinking that our vaccines are so and so, but it was too short time just to explain to people that vaccines are good. And that's why we have Rora.
Mm-hmm.
Thank you, Bettina.
Yeah. Well, this is now boiling the ocean, right? So I think to be a bit cynical about it. I think what will help us with personalized medicine is that it takes large data sets to make any use out of them. So you can't, you can just take a handful of the super rich who can do the fanciest, genomics, proteomics 5 times over if you like, but the data set is going to be totally uninformative. So the information and then the value will only be leveraged if we have large data sets. And then you can think about scale and pricing and some IP rights that are running out shortly and some other initiatives. And then I think we will be getting, because the value for everyone lays in the size of it. I think that's the first one part of the question. The second part is concretely between Bulgaria and the Nordic countries. So I live in Sweden, and so very concretely, because I've spent the last 2 years on the European Cancer Mission Board, so I had my nose into EU programs like this for the last 2 years. So very concretely, there are a number of programs one can already today apply for. I started for my own network, Melanoma Patient Network Europe, a Central and Eastern European platform 5 years ago, something like this. And often if one goes into the countries in Central and Eastern Europe, people complain a lot how bad everything is. Of course, you can always compare, and we can all compare to Switzerland or other places. And of course, we're all going to look somewhere shabby in some places. But if you think about what these countries have in terms of energy and willingness to try new things and the speed with which things have developed, if you look, where do the tech startups sit now? Where do we have lots of young startups and people with entrepreneurial mindsets, people who move? They sit in Eastern Europe. So where will we get the leapfrogs? It will come from that region. So please, please, please leverage that, make use of that, look for these Horizon programs. And often, and that's one bugbear of mine, is that people fail because they can't write grants. It's simple things like helping people to set up consortia, write better grants, help people with ideas to be successful. And that's a very concrete first step where I think you can leverage what you already have at a very different scale. And it's simple things. It's often not the big, it's the connection, it is the support, it is small things. Other countries have been doing this for a long time. I mean, today, if I wanted a great grant application, I would find a Spanish agency. They have fantastic agencies. They know how to write this stuff. Copy it. That's very concretely to move. They're great people. It's a matter of the interconnection that's not there. We can otherwise talk about, how long everything takes, but I'm always impressed because, our conferences and our programs, we've been to Zagreb and we also have been to Skopje, and so now I'll be in Riga next week. So it's, it's amazing what's happening there. Leverage it.
Thank you. Next time is Sofia, right?
Oh, well, if you invite me, of course.
You are invited. Bogi, you, as an ambassador of the Biotech Atelier, now you have the right to wrap up everything.
Well, yes. Thank you, Dimitar, and thank you all for this very, very nice session. I think it's very, very important to have in mind that I agree with what Bettina was saying here, that the opportunities are big, but we need to see them. One bottleneck is the structural way of making applications, yes, but I think the huge opportunity lies in that it's a paradigm shift, or at least half a paradigm shift that we need. And that will likely not come in the most established societies because it's too locked into the old way of thinking. Bulgaria is quite strong on working with data, not necessarily in health, but in general, the digital functions and data. So I think also what we heard here is an urge not only to catch up, but actually to lead in some things and find new ways of doing things. I'm really also happy to hear that there is an optimism on applying the new biology, as we call it, so the genomics, the proteomics, and the other parts, and it's feasible to do it even if the first steps are more expensive than we hope it gets with time, and also that the health literacy to get people to understand what is this about. And here is my point that I've raised many times the last 20 years. We can discuss as much about ethics in genomics as we want to, but it's not an invention, it's a discovery. I mean, even if you don't like genomics, it's still there. I mean, you can just refuse to look. And that is something we have to take into account when we work with these things. And I think the key to data, which we also heard today, is to get our focus on the application of it, the usability of it, and then we need to figure out how does that work in the modern world. And I'm pretty sure that a combination between the Nordics and Bulgaria here, we can actually get the best of two worlds. So this is also my urge to everybody here, and I will also try to do my part to push this agenda.
Thank you very much, and thank you for everything to all panelists. I spent some unforgettable 75 minutes with you. Thank you for your contributions. Now we have a comfort break and continue with the interview with Professor Stefan Tirstrup. Thank you.